welcome back to BurnCast. Again, we have me, who you're used to seeing, and Anne and Liz. And today we have a special guest, highly recommended from Carrie Tully. Today we have Najma, and she's the education coordinator for the National Rehabilitation Hospital. Najma, thank you so much for being on our BurnCast and sharing your expertise with us today.
Thanks so much for having me. I'm excited.
So could you first, my role, I'm an injury prevention, education, and outreach coordinator. And I know what that means for me, but I would love to hear what does education coordinator for NRH mean? And can you tell us a little bit about the role?
Yeah, well, it means a lot of things. So one of the main things that I do is take a look at the patients that come into our program and think about their recovery, their illness, their injury, their progress, their personality, all of these things, their family unit, and how all these things will translate into them returning back to school. And so what that looks like is kind of very early on establishing a relationship between the patient and the family or the caregivers and the child's school or school district to kind of start getting everybody in the loop and serving as that person that's doing that communication. A lot of the times for our families, it's their very first time having to think about their child needing special accommodations at school, needing a change in instruction, needing a change in how they get to school, how they move around the school environment. And with all of the many things they're trying to do to care for their child, that's something that I can kind of take off their plate, but also walk them through so that they're empowered with the skills and the knowledge as they continue throughout that process. So that can look like anything. A lot of times it looks like establishing individualized education programs, which you may be known to call IEPs or 504 plans, or even kind of more informal plans based on the time frame and how gradually we want kids to return to school just based on their needs. So a lot of times it's that. Sometimes it's thinking about a change in placement for children who have had a very significant injury or a very significant illness that now will make the school that they were going to attend potentially not the best fit. That's usually kind of a last resort, but can happen. Sometimes it means going to the school and kind of seeing what the layout of the school is and making sure that it's safe, that it's accessible. We've had students who attend private schools where they have kind of very old buildings and things like that that are not always super accessible, and maybe they don't have a lot of students with disabilities. So we've gotten buttons installed and different kinds of things to make schools and school campuses more accessible. So really thinking about an individualized approach for each student that we call their kind of return to learn or ready to learn plan. So it looks like that. It also looks like making sure the children have education while they're inpatient. So sometimes that means me providing direct instruction. In most cases, it's coordinating for them to have education services through their school district, through the homebound office for that district. Every district has a home and hospital program with teachers that work for that program. And so establishing a plan for their education in addition to their therapy. Now, for students in private schools or school districts that don't have that program, that's usually where I will step in and provide that instruction or get it provided some kind of way. So those are the two kind of big buckets of what I do. Also just kind of being a resource for the team as they, for kids, we're thinking about preparing them for return to school, just like for adults who think about preparing for return to work. So making sure that therapy looks like also activities that are applicable and transferable for return to school activities and for that part of for our kids' life.
So what's your degree?
So I have a bachelor's degree in psychology. I have a master's degree in education and human development, where my focus is on special education, but really on students with emotional and behavioral disorders. But you will find that it helps all across the board.
I bet.
Yeah, and I'm also in a PhD program right now for educational psychology.
Oh, that's awesome. Well, congratulations.
Thank you. Thank you.
Yeah. How did you get to this job?
Yeah, it's a good question. Yeah. So, I mean, for me, my love has always kind of been like right at the intersection of psychology and education. And so, kind of using psychological principles to solve educational problems. And that's kind of what kind of started to draw me toward special education. I started out in education research, then felt like, how am I going to be a researcher if I'm not actually in the classroom and I don't have the experience there? So spent time as a teacher and then worked in leadership positions in special education, both in like a private school that was like a therapeutic setting, and then also for Arlington County Public Schools. And so I was already kind of out of the classroom, but getting to be in the classroom as a support, but really began to love working with parents. And that's a lot of what my role is now, especially in light of the pandemic and how kind of messy and tricky things are. Really being able to be an advocate for parents and being able to look at a child and assess what's going on with that child and figuring out kind of what are the puzzle pieces that are going to make this child be able to access their education in a way that brings out how smart and wonderful they are. And so when I was looking for jobs, this position came up. And the more that I learned about it, I also get to do a little bit of research in my role, among other things. It would be long if I told you all the things that I get to do. But it kind of gave me the opportunity to do all these great many things that I really enjoy. Being able to once again, look at kids, see kind of what they need, learning the medical side of things and all these different various illnesses and injuries and all that. That's been a learning experience, which has been fun for me. I feel like I get to know more, but being able to be a part of this small team, I really love, that's all working for a common goal for these kids, getting to work with parents. So it's just really become like a natural fit, and I love it.
What do you think? Because we're obviously, this is a BurnCast, so we
Yeah.
want to talk about all about our burn patients, and
Yeah. Let's do it.
even though we work for trauma and burn, we're focusing on just burn today. But what do you think is like one of the biggest hurdles in going back to school with any of the kids that you have like helped that help that process? And does every kid need like a specific program, or
Yeah.
I don't know, I guess I have a lot of questions around that, just that.
Yeah. I mean, so burns became something that I didn't see at all when I first came to this job. And then I saw all of a sudden all the time. And so, and I'll tie this kind of what I think ends up being the barrier. And I really think it's apprehension. And that can be apprehension from the child. It can be apprehension from the family. It can even be apprehension from the school. And so I think for me, the first burn case that I had, which was a pretty significant one, I think that we can all agree that seeing a child that's burned very severely it's devastating. But what I learned very quickly is that though I thought it was very devastating, the child was kind of like, what? you know, sure, when they're getting their dressing changes or they're dealing with the burnness of it, right? They can be upset. But the rest of the time, children, is wonderful as they are, they just adapt. And so once I, in my first day working with my first burn patient, saw like, this kid is not even worried about this burn, or at least they're worried about it significantly less than I am, then that kind of really helped me to see like, this is the pathway that I'm always on, right? How do we get this child to be able to show up as this child in the school environment and get everything they need, and put the things in place that are going to help them be able to learn and not be impeded by what's going on. And so I think for kids, particularly our kids that are a little bit older enough to kind of know what's going on, that apprehension can happen about going back to school, about people seeing them, about what it's going to be like. Also, just like all the love and attention and care that they get in the hospital. And then especially when they come to our team at NRH and they spend a long time with us. And now it's just like, I get all this attention. I have a teacher here. She works with me one-on-one. They almost get like, I don't want to go back. Right. Or families can be more apprehensive than kids are, than we are, that feel like, oh, our kid's going to say something, what's going to happen. Families can get very anxious, and schools, and that's why it's important to make that connection with schools really early. They can kind of get like, well, how are we going to care for this? Especially if it's their first time, right, having seen it, or especially when it's something that has been particularly traumatic. Schools get a little bit almost they lose confidence in themselves almost to be able to accommodate and be ready for our patients. And so that's the thing that I think ends up being the barrier. The rest of it we can kind of work out. And I think that how we address that is early kind of interaction. So that might mean me interacting very early with the school. That might mean very early creating little Zoom meetings where the child gets to at least meet one-on-one with their teacher, or setting up little meetings where they can meet with their friends. Before COVID, we would invite school personnel, we would invite friends onto the unit, that kind of thing, to just sort of normalize, right? And for even the teacher and the child, or the principal and the child, to see like, this is all the same, right? We have this thing, we're going to figure it out. But that apprehension can kind of create the distance. And so I feel like that's the biggest thing.
Yeah, I can see that. I guess I never really thought that a school would be like a barrier. Liz, Anne, what do you think? Was
No,
that
I just had
interesting to you?
I just had a question about, so what does that core team at the school look like? Is it, guidance counselor, principal? I know you mentioned teacher and, some close friends, but that's really fascinating to me that you have such a good team over there. Who all does it include?
Yeah, so each school is different, right? So every school is different. Every school district is different. I work with schools all over, right? And so you will start to notice like certain trends, but some schools are just have a really big like can-do attitude. Some schools, especially when they're kind of overworked, or right now with COVID, not just with burns, but we would see a lot of pushback kind of with readiness for our kids to come back to school, because schools are kind of like, we're already, like, are you sure? Like, are you sure you're ready to send them back? And we're like, it's fine, so that kind of thing. But the school team that's usually involved, so usually it's the grade level counselor. If we're looking at an IEP, the school psychologist will get involved, which is almost always a great thing. There is usually a classroom teacher that's involved. If we're looking at an IEP, a special education teacher will be involved. The parent we want involved, and then usually some sort of administrator. So usually like a grade level administrator will be involved. So that's kind of like the crux of the team. Now, some schools have like other fun people that are involved. Like I'm the family support resource person, like I'm the person that plans all the fun, and that's great, right? And then we have kind of like more things that we can put around. We also try to find out if there was an adult at the school that the child was particularly close with before an incident or a trauma happened, and then we really try to build the connection through that adult. And that doesn't have to be their teacher for that year. It could be whoever it is, and we try to keep that person involved because we know that they have a communication pathway with that child or with the family.
That's great. Wow.
What does it look like in terms of the peers? What do you do for their friends or their classmates, kind of in terms of their reentry with that?
Right. So every kid, again, is different, right? What we usually offer is some sort of, and not just with burns, but with most of our kids, the opportunity to create some sort of story about their hospital stay, where they can create like a PowerPoint presentation or a poster or some sort of creative project where they're kind of talking about what happened. And then usually we add that into like the goals that they're doing. So that might be an educational project that they're working on with me that also has some speech goals where they also make it cute and fun and therapeutic recreation, right? And so we kind of try to work it in. And then what we'll usually do is have them present it to us toward the end of their stay. We also give the opportunity for them to be able to present it to their class, or for there to be some sort of presentation that they've created that their teacher is going to share with their class or their peers before they come back to school. So usually one of those methods. Before COVID things got weird, I would spend a lot more time in the school. So usually what would happen is we would pick a day where like there wouldn't be a lot of kids, maybe the end of the day or like a PD day. And then we would go back to the school and just walk it together, right? This is what it's going to be like. We would have maybe 1 or 2 staff members there. Do you remember your locker? Let's open it up. And it was great because not only is it like a normalizing, readjusting thing, but we also get to figure out where the problems are, right? So we can start to see like where are the barriers, where are there things we need to fix. Sometimes we might invite one friend to be there, that kind of thing. Like I said before, we would also try to set up things like on Zoom where they talk to a friend, or even where they do like a small group class. Our kids can't usually meet with their class all throughout the day because they have therapies, right? So we usually try to set up maybe one class where they join, normally like lunchtime or homeroom, where they can come on and say hi, that kind of thing. But usually the PowerPoints, we have books that we'll recommend that the teachers can read for little ones to read for going back to school. We have a kind of a list where it can cover things that are not necessarily about burns specifically, but kind of speak to, someone looking different, or stories about bullying, or how to ask people questions, things after someone was sick, that kind of thing. We also do some role play where we'll have like the kids, we kind of like imagine a scenario, like, what will you do if someone asks you this? What will you do if someone asks you that? And let them kind of practice and model the language that they would use.
That you have the coolest job.
I know.
I
was like, it's really neat.
Sure is.
Go ahead,
I have
Liz.
a random question. How many, I guess, patients, how many kids do you work with at a
I was
time?
thinking that too.
Variable, but
Yeah.
that's a ton of work. How many?
It is. So that's a tricky question. So before the pandemic, we had up to 13 beds that we would have on our unit. And we got kicked out of our hospital, and we were kind of temporarily over with you guys at Children's, had a little bit less. Now we have another temporary home at HSC, Hospital for Sick Children, where right now we're only able to have up to 6 patients that we're hoping is going to be more. To your point, yes, it can be a lot, but usually now there are some time periods where we get like a whole bunch of 3-year-olds or a whole bunch of middle school boys, but it tends to be very different what the patients look like. Maybe there'll be a pair that's similar age or something like that. But for the most part, it's different. They're not all ready for education at the time that they come to us. And they're usually not all returning to school at the same time. In fact, we try to make it that way because it becomes a little bit of a mess. So that can be like, we might have a 3-year-old, we might have a 17-year-old who's a little bit more able to kind of navigate things on his own, right? So there are times when, yes, it can be overwhelming, but it also depends on the support system and what the school looks like that the child has come from as well. There are some kids that go to schools where we let them know that they're there, and the school's like, we know that, and we got it, and this is our plan, and these are the people that we have, and they're just kind of that way. And then there are some schools that need more support, just like you see with parents. So it kind of fluctuates.
Yeah, I was thinking the same thing of like, how many kids can you possibly do this with at a time?
Well, yeah, and what's tricky for me is a lot of our work happens also after kids leave, right? So one of our program goals is for all of our kids to return to school within 2 weeks of the established plan that we've created, right? And so if they leave us and they're still on home and hospital instruction, that means I'm still following those kids until they physically actually, go back to school. And then we check on them. We want to know what's going on. And so that's fun. But yeah, for the education part, it doesn't end as soon as they leave.
Have kids ever gone back to school and then for some reason do they ever end up back in rehab?
Yeah. Yes. That usually means something went wrong.
Right. Yeah. No, I was just wondering, like, how does that?
So yeah, for kids that have like more of a long-term illness, right, where they might have repeat hospital stays, or they might have something where they have a surgery later to fix something and then they come back to us for a little while. Yes, that happens. Those kids and their families tend to be actually a little more well-versed in the overall process, right? So they actually end up needing kind of a little bit less support because they kind of know what they're doing. They do this all the time. We have had it where, we can make recommendations for how we think students should be supported when they go back to school. Sometimes, at the end of the day, it's really kind of up to the parent in some ways. And so sometimes parents, as I'm sure you've seen, have a hard time accepting that their child might need certain kinds of supports, or accepting that their child might need additional, a slower return to school schedule than that which we recommended. And so sometimes they go around our recommendations and kind of do what they want to do. And then maybe the kid ends up not being ready to be back at school, and then they're back at home and that kind of thing. And then we have to kind of fix it from there.
What do you like, how do you handle when you know a kid is ready and the kid knows that they're ready, but the parents aren't? I think that I feel like that's something that we probably all struggle with in various ways of like, we all know how resilient kids are and
Yeah.
how brave they are, and they can handle like, just even when you described like earlier, like the first time when you saw like a burned patient, you're like,
Yeah.
oh geez, and they're like, okay.
Yeah.
Like
Yeah.
how do you handle like those family dynamics when the parents are here but the kids are here?
So my trick is usually to set up a meeting that I'm not calling a return to school meeting. I'm calling it like a check-in or like an update meeting with the school, but I ask the parents to bring the child. And then usually what happens is the child comes into the school. Everyone is delighted to see them. They've made them a big poster. They see the child start communicating with their teachers or maybe some of their friends. And then something kind of clicks for the parents where they can see like, oh, okay, now I see my child here. I can recognize that this is a place where they're supported. If that's the situation, right? That's best case scenario. It's a great school and the child's going to be supported there. And then that kind of helps. And then even if we don't do that piece, sitting down with the parents and the school to talk about, because a lot of the time is parents don't know what sorts of supports are available at schools, right? If your child has been otherwise, fine or quote unquote normal, right? You drop them off in the morning, they had a great day, you see their report card, you hear about the fun stuff, right? But they're not really aware that there's this whole other world, particularly in public schools, of supports and people that are there to help with these sorts of things. And so once they start to hear about the different kinds of programs and the different kinds of check-ins that can be there and the different kinds of accommodations that can be there, like parents will say to me, like, I don't think they can go back because they're going to need this and this and this. And I'm like, oh, we could, we can do that. That's no problem. But they don't necessarily know that that's the case.
So yeah, I guess just from the knowledge aspect, and I mean, why would you know about a bunch of special services if your child really never required anything but like regular learning stuff?
Right. And unfortunately, sometimes we do have to force their hand, right? So there are times when we know a child is ready to go back to school, the child's ready to go back to school, and they can go back to school by this day. Normally, we don't do it that way, where normally we kind of try to get all on the same page. But if we've established and it's signed by the doctor that they can go back to school on the 8th and on the 10th, there's not a reason that they're not at school. Now they're starting to get those phone calls. They're coming to me. They're like, can you write another letter? And I'm like, nope, let's go to the school. We can meet, but sometimes we do have to do it that way.
Does that happen often?
No,
Okay.
not more than it happens though. But if that happens, that usually means that kind of throughout the hospital stay, maybe there was kind of already that kind of disconnect with the family. And I'm sure you've seen that where sometimes it's like the expectations of the parents or the presence of the parents are not exactly where you would want them to be for them to have a full because it's really a gap in understanding, right, of what their child is capable of, or they have become so fearful and so anxious and where they are in their own recovery about what's happened with their child is not meeting where the child is. So normally we can try to stick our psychologist on them and hope that she can work with them or try to get them in more or do a family conference. But that would be how we address that.
I think that also is really great because it speaks to, the services you provide really speak to for me as another reason why to encourage families who are sometimes resistant to go to inpatient rehab. They're like, no, we're fine. We just want to go home and we can do therapy outpatient, or we can, who are really, and I truly understand that you just, after being in the hospital for a long time, just want to go home, but there's so many other really important transitional pieces in addition to that physical and occupational therapy that you provide. And it's just it seems like such a gem of a transition that you can help with that as well, which is notable for me as a provider to kind of another benefit of making that inpatient rehab transition.
Yeah. And to your point, these pathways are difficult to navigate, right? I also think it's important that we understand that schools are they're understaffed and they're a little undersupported. And when we get our patients in, to me, this is the most important child in the district, right? But for the school, they've got a long list of kids that want evaluations for lots of reasons, all these things. And so it helps to have someone that's kind of like on your team, or people on your team that are saying, this is a priority, this is how you do this. If they tell you this, you say that kind of thing. Because a lot of it is that, like, I have parents who call me like, does this sound right? Or like, can I send you this? Because, just like in any field, right, we try to prioritize who, what to do when we're overwhelmed, when we have a lot of patients, when we have a lot of students. And so there are little tips and tricks that, we're able to give parents to help them kind of move their kids along through the process.
I mean, I always thought an RH was great, but
Oh, it's the best.
this is like even better. I did my nursing clinicals for nursing school at NRH.
Oh, awesome.
And yeah, there was a very small number of kiddos, and it was actually at NRH. It wasn't like a satellite, but
Yeah.
that was my pediatric experience.
Oh, I love
Was
that.
NRH, yeah.
I'm hoping they'll bring us back to the NRH building, because our unit as it was just very, very special, with everybody really focused on peds, kind of all housed together, just a very, very sweet space. And so we're trying to create the same thing at HSC, but nothing's like being back in our old space.
Do the kids in rehab help each other? Like, do they see each other, or do you see that more of a benefit or sometimes a hurdle, or probably both, but
So that's a COVID sad thing, right?
oh yeah.
Before COVID, all the time, our kids were never in their rooms. They were always hanging out around the nurses station. We had a classroom, we had a dedicated play space. All the time they hang out together. And so that's kind of like that first defense of the normalizing, right? Because they're getting to play with other kids. I can watch them do that. I can see what starts to come up, right? All that kind of stuff. So now it's discouraged, strongly discouraged that we do that. We do try to do things where the kids are maybe doing the same thing at the same time, like going to the playground, or we went out and had a pizza party outside, that kind of thing. But being able to, actually, when we were at Children's, we let them do the what is that, Jeopardy that you guys have?
Oh yeah, with Seacrest Studios.
Yeah.
And yeah,
They love that kind of thing. So where it's like independent, but they're in the same space.
oh, that's tough. I didn't even it's just like another like arm of COVID that I think that we probably didn't even appreciate.
Well, speaking of COVID, I will say, in terms of burns, that was when we really started to see burn patients in COVID a lot. And so I think for me, it was a time that I felt very sad, because I could really see how COVID had kind of impacted kids from both directions, both like at home and through school. I think we all know that like school is more than just kind of like where you go to learn for a lot of kids. It's a safe space. It's a place where there's people that are checking. It's a place where supports are being provided to families, where kids are spending extra time, where they're eating their meals, all these kinds of things. And when COVID happened and those schools closed, we saw a lot of kids that were kind of like on the bubble, where maybe their parents were under a lot of stress, but they were receiving support and check-ins all the time, or they were getting that extra supervision. Once that was lost, they ended up in situations where they got hurt. And a lot of what we saw them getting hurt by was burns. And so that was tough to see, because it's kind of one of those things, and COVID has had a lot of legs. And so, we're privy to see the ones that we see, but we definitely saw more of that. And when that was happening, that also meant we had kids that were coming in that not only had very, very significant burns, but may also have been undergoing a child protective services investigation, or had a home situation where they didn't have a lot of supervision, or maybe weren't going to be able to have all of the support. So we would want them to have going home after a burn, maybe not even going home with the family that they were with prior to coming into the hospital. And so that was really tough. And then also having schools be closed. And I heard even just the grief from educators who are very close to these children and close to the families, who felt even personally responsible that they didn't do something more to make sure that families and kids were okay. And so that was really a tough time involving Burns during this COVID process.
Yeah. Is there anything like specific to Burns other than other reasons that kids would go to NRH that make it easier or more difficult during this whole like back to school process? Because I mean, I'm trying to think of like all the reasons like a child would go to NRH. So I mean, obviously probably like an amputation because they have to like learn how to do life without an appendage. You know, head injuries, you know, all of the things, but like, have you noticed anything specific about Burns that's different, or the kids in rehab pretty much all have like the same needs?
Story with the Burns, you mean?
Like, is there something different with Burns other than just like all of the other reasons why a kid would be in NRH?
That's a good question.
And I asked that for really for our nurses to maybe and our nurse practitioners and any provider to see if like you have any like specific and helpful insight on this, like the special populations, because Burns are different. You will have more than likely, if you have a burn that has landed you at NRH, you are always going to have something on your body, no matter what, that reminds you of this time. And unlike some things you really can't see, you can like tell by certain behaviors that's maybe something had happened, but you can't physically see things. With Burns, it's so out there.
Yeah. You know, I'm trying to think of what the trends are, and I can say that we've seen them kind of across ages. We've seen them across genders, and across different types of families. You know, there are these like super, super accidental kind of circumstances that happen. I would say in most of the situations, there was some sort of, there was kind of already a pre-existing maybe kind of issue where there was something that was impeding the parents from being able to be at home, where children were caring for their siblings, that kind of thing. That usually something where maybe a very adventurous child who tried something that maybe they shouldn't have tried. But those are kind of like the buckets that I have seen. I'm sure there are many, many more, but those are just the ones that have kind of come across while I've been there.
Yeah. So how can me as a bedside nurse and Anne and Liz as trauma and burn nurse practitioners, what would you say we could do more to support these kiddos before they get to you? Because I'm assuming that any kid that ends in NRH that's of school age is going to meet you and you're going to help them.
Yeah.
Is there something that we can do to help the parents prepare, help the kid prepare? And it doesn't even have to be about school, but just to get them ready for rehab, because it's not something that we do all that frequently. Would you agree with that, Liz and Ann, that we don't send a ton of kids to NRH, but like what can we do as providers to get them ready for, you know, for eventual like normal life? Like, what do you see we could do better?
Yeah, I mean, I think some of it is just automatically starting to communicate with the child about their life outside of the hospital, which I'm sure everyone already does. But the more the child is thinking about school, the more even if there's not, I know at Children's, you guys, I think, have education specialists for the cancer and blood disorders units, but not for the other units. But there are already things that the social worker can do. Sometimes I get kids and maybe the social worker has already made a connection with the school, and that's already happened through the family, and that's super helpful. Or the child even just hearing about school, where you're asking them, you know, what do you do at school? Where maybe you give them a math problem when you come in and visit them, that kind of thing. Because sometimes we get kids and they're like, school, I didn't think I was going to have to go back there. What are you talking about? You know,
I thought I was done. I thought I was good forever.
Yes. That I would also say helping kids kind of maintain a routine. I think a lot of times what we see when kids come to rehab is that they might initially struggle with a routine. So especially for little ones that are still of nap age, I think most kids are still of nap age, but having them have a time of day that's like a quiet time or a nap time, kind of thinking of the kid's schedule the way that it would be when they are at school, just kind of keeps that continuity, right? Where they're getting up maybe at a certain time in the morning, or you're communicating with the parents about why that might be beneficial, where they're having their meals at a certain time each day, if possible, where they have quiet time. I don't know if you guys have like a library where we're encouraging them to read or do, you know, I know for the most part, especially with our burn kids, we want to keep them comfortable and happy and safe, and they deserve that. But they also deserve to feel like normal kids, right? And so sometimes that means making them do things that they don't want to do, or having them stick to a routine, or kind of know exactly what to expect for the next day, and reminding them that like, hey, you're a student, we got to get you back out there, and you know, what do you want to be, and all that kind of stuff.
And I think that's where inpatient, kind of speaking to your question, Cindy, is our child life therapist can be really beneficial with that, because and may not be there every day to do every activity, but they can help. They oftentimes will help us set up a schedule for our patients. And that's something that when I request a schedule or really want to put in the schedule, like it's not just because I want to be a little bit more organized, right? Like it really is beneficial for the patient to have their nap, to have their time where therapy is not, to have their time where therapy is, to kind of get their meals in there. And I always say, even if they're not going to eat anything today, or they're not feeling up to it, let's still have the meal. Let's still order the tray. And if they have a bite, that's fine, but it's still, that's your meal time. And then later is not your meal. Like you really setting back into that routine, because that's something huge that I think bedside nursing can really help with, is if a patient does have a schedule, to try and stick to it as, you know, within reason as much as you can. But some of those things can, and you spoke about books and things. I think Child Life can help with some of those things, but also really having bedside nursing really empowered to assist with that as well.
Absolutely. A lot of what we saw, especially I'm thinking about a few of our burn kiddos, they would stay up very, very late at night, and then they would want to sleep in the morning, and there wasn't really like an established meal time, right? So then the first couple weeks of rehab are just like, all right, let's get you kind of back on this routine where, like, you know, and then they've had so much fun with Child Life, right? So they're like, everything's supposed to be fun. I want to play my game. I want to do my this, right? And so there's a little bit of that transition. So I think that all of that, and I think just early on starting to, just like I think all of us do as providers, is trying to identify strengths, right? Identify the strengths in the family, kind of start to get an idea early on for like, who's that person that seems to be around the child that might be the person that could maybe start to communicate with the school. Maybe they can, you know, they don't need me necessarily to go drop by the school, or have an adult drop by the school and pick up books, or pick up, it doesn't even have to be books. It could be cards from the school, right? It could be messages from their teacher. It could be a basket, that kind of thing. So just starting to identify the strengths. If you hear, you know, something come up that sounds like school related, or it sounds like an adult or someone that might be really strong for that kid, just kind of dropping that in their ear.
Yeah, I feel like that's really helpful. With like understanding why that schedule, and like normalizing their life even when they're inpatient. And I feel like as a bedside nurse, that can be really difficult to do, but I think it's really important. And in the long run, I think it's really helpful for all the providers as well, because you know, if everybody's on a schedule, that consistency is so helpful. Liz, you look like you wanted to say something.
No, I guess I was just thinking about the fact that, you know, especially when kids are younger, I mean, school is such a special place. They love their teachers, they love their friends. You know, and I'm sure that it's upsetting to classmates to not have their friend in the classroom. So I really like that idea of, you know, of just trying to normalize as early as possible, and to get them back in that setting that is just so special, and really reflecting too on how kids do so much better with their routine,
They do.
whether it's a weekend or the long summer. So those are really some important pearls that I think, we'll all try to focus on.
Some schools do really cute stuff. They'll put like something in the child's chair. They'll take a picture every day. They'll write a message. Teachers they're magical people. So they come up with all kinds of fun things to do. But I think, it's important that kids know, like, hey, you're not being forgotten about there, maybe saying to the parent, have you heard from the teacher, things like that. Because most of the time, I would say like 85% of the time, the school wants to know, like, what can we do? And so I think once that gap starts to go, right now, they're thinking about all the many other kids, but getting it, the earlier, the better.
This has been so interesting. Thank you so much for answering all of these questions and being so open and candid with your answers. I kind of want to spend some time at NRH. And as we wrap up today, and I'll start, I'd love for each one of us on this call to say, like, what's the one take home point that you would want providers to know? And and what do we like get from today? And Najma, I'm going to have you like bring us home with like, what's the one, if you could tell bedside nursing or providers one thing to that would help this process to help kids normalize, that would be the thing. What I really got out of it is the understanding that parents really don't know all of the resources that are out there, and that sometimes just the knowledge and explaining that there are so many things to help you. You don't have to do this alone. And like, there's no shame in that. I think that sometimes our families are feeling some sort of way about that they're now they have a child and they're injured and they're having guilt over that, and then now their kid is like different and needs something, but letting them know all of the resources that are out there so they can get back to their baseline and get back to everyday life. I think that just knowing that parents don't really know that was a real eye-opener for me. What about you, Anne?
What is my number one? I think one of my biggest ones is, which I already spoke of, is that I think there's so much more to offer. A lot of providers haven't been to NRH or don't really understand. They think you get some therapy and then you go home,
like PTOT.
Or
and they're fabulous too.
which is the whole point, right? Like one of the big points, but I think it's really helpful to know that there's so many other services, and that this school reentry is a huge, and just this life reentry is just a huge part of it, and resources that speak to having the navigation that the parents just don't know. So I think that's really big to know, that there are more benefits than just doing physical or occupational therapy to inpatient rehab.
Liz?
And that this process can start, as soon as the patient's on the floor. We don't have to wait for rehab. That there's so much that parents can do, especially, and to have that early communication with the school and to really encourage that. So I haven't really thought about that. It seems that we're so focused on the physical so many times, and dressing changes and pain management and nutrition, that really this is such an integral part, and I think can really complement all of the care of the whole child.
Yeah, I agree with all of that. I will also say that being able to collaborate with Dr. Tully was phenomenal for our patients. And so to your point about the whole child, right? Kind of like in this case, the more hands we can get in it, the better, right? Because, and that's not something that we really spoke about today, but like in addition to what might be physical concerns, what might be your normal apprehension and your normal anxiety, we sometimes see really severe anxiety. We sometimes have kids that are really significantly suffering from post-traumatic stress. or we find that the circumstances that potentially led to the burn kind of bring up some other more issues that need to be addressed by psychology. And so we have a psychologist on our team, but and she's wonderful and does that for our program, but even she has kind of punted some of these to Dr. Tully, who really can specialize in these areas. So I think the more people like that, the better. Getting more people involved in terms of pain and pain management. That's an area of growth, I think, for us over at NRH, having someone who's kind of an expert in pain, and also kind of even educating the team or educating other providers about pain and what pain looks like. And do kids over-report pain? Are they under-reporting pain? That kind of thing. There are so many different areas, I think, of expertise that kind of come together. And the more of those that are involved, actually, the better we can equip the family and the better that we can equip the school, because they will ask me those questions. And sometimes I have the answer and sometimes I don't, but it's really helpful to be able to have more evaluative, more expert language. I will give you one example before we go, but in order to get these services, we do have to apply for them, right? And they do have to be approved. And so we had one situation in which our student was very significantly burned, but also very smart, very energetic, very high functioning. And we wanted to get him an approval for home and hospital instruction, where he would have an individual instructor to work with him until he was ready to go back to school. And that application was denied because of how high functioning he was. If we had not already been collaborating with Dr. Tully, who was able to then help fill out that application from the psychology side and also validate that this child was suffering from post-traumatic stress disorder and give psychological reasons why this child would benefit from a small group or individual setting, he would not have been able to get what he needs, right?
Wow.
So it's just really,
that's huge. That's really huge.
important to kind of peg, these different people that can kind of come together and create the best plan and the best outcome for these kids.
Wow, Najma, thank you so much. You do amazing work, and thank you so much for being on our BurnCast.
Anytime. And feel free to,